Good morning to everyone, and thank you very much, Dr. Kanchana, my friend, giving me the opportunity to talk to you all. Um, so it is very nice to see you all after some time, and I can see some of my teachers sitting here. That is very pleasure even. So hello, 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 hello. Thank you very much. Um, Thank you very much, Dr. Anjana, for giving me this opportunity to talk to you all. And I can see a lot of familiar faces sitting here. So what I thought was to discuss you all with my some experience and good results of my work. So place I work in Kurunegala. So this place is, I think some people are familiar with this place. When you go to the peripheries, after taking your all these training from big centers, you have a lot of problems. So you have minor facilities, no training staff, but you are getting a lot of patients. But at the same time, you need to give them for some reasonable solution. So those are the my question when I work in the peripheries. So little bit of statistic. So Kurunegala, even we say this teaching hospital, our unit is small. We have only 20 beds, one for 10 bed for one ward, only one theater table. So we don't have a separate ICU for neurosurgery. So we have to share all these things with the surgical lines. They have only 12 beds to cater all these complicated surgeries. So with this whole problem, for last 12 months, we have performed more than 1,000 surgeries, major surgeries. That is quite large number, I feel. So we keep up daily casualties, two clinics. So fairly big, heavy unit, even though we have a small unit. So not related to neurosurgery, I mean. But if I ask question, what do you feel about neurosurgery? So what are thoughts? So different people will come with different ideas. Right? So this is one of a common idea on neurosurgery. I think you all know about it. So people say patient coming to the unit, neurosurgical unit. Some people they are walking up to the unit. Some wheelchairs or trolleys, right? So this is my job. You take this part out, dig into the brain, suck this out, hours and hours, right? Finally, they are going with this one. So I think this is a common the story about neurosurgery. So people talk this one. So when you go to the neurosurgery, this is the result. So people are so scared about this problem, neurosurgery, dying problem. So my idea is to just wash away this bad idea about the neurosurgery. Right? Neurosurgery people think that's so complicated. So basically, I want to share with you all some of my experience, what I did in this Kurunegala and the results. So we'll start with the small case, small thing. This is one common problem, meningiomas. So when you talk on these theories, hello, okay. So I don't want to talk too much about the theories, but if you can remember very few things on meningiomas, it is worthwhile. One is these tumors arise from the dura, and majority of them are benign. Various histological types, maybe more than 10. But this is a main message I want to give you. So if you can do a complete excision, you can cure the disease. So that is the main point for me. So if you come across the meningioma, patient have the meningioma, our aim is to cure them. So spending a lot of time planning it, doing it properly, you can save many patients' lives. So that is my point on this meningiomas. You can forget all these things. So give these things for us. Keep this one with you all, right? So this is a very simple form of meningioma. We call cortical meningiomas. So this is a CT scan. This is a MRI scan. So this MRI CT scan, you can see a big tumor coming here, compressing the ventricle, little midline shift, and this is the appearance of a MRI. So you can see the big tumor coming. This attached to the dura. So I am not going to discuss too much about the MRI finding on this case. So this is how you see when you open this tumor. This is what I did. So this is a very simple surgery. Outcome is all right. So not a complicated one. So if you can make a correct craniotomy exactly over the tumor, so tumor will laugh at you just to take it out. You can take good results. So you can see the bone coming here, and this is a thin layer, a dura, and this is the brain tumor or the plane. So you have taken the little bit of tumor out, and complete excision can go. These are not that complicated cases. So this is somewhat complicated than other cases. So basically we name the meningioma according to the white line. So this area, the sphenoid wing. So the tumor is sitting on the sphenoid wing. So we call it sphenoid wing meningioma. This is simple the definition. So the story behind this case is, a 50-year-old lady, around 50-55, came with the weakness, analogies, yes, but improve with the years, improve with the dexamethasone and the medical treatment. And if you check on this MRI, so there's some point for me. So you can see the brainstem, upper brainstem pushing this way, and this area. So you can see some black mark, dot like thing, right? This is an artery. This is a middle cerebral artery going, touching the brain, the tumor. So we are interested on this one. And when you check on this coronal view, you can see tumor is going up and to the middle base, and you can see some tiny dot coming here. So these are vascular territories. So complicated than other one. So if you can take the whole tumor out, saving this tiny artery, your surgery is going to be very successful. So this is the point. So locating this artery, saving this artery, and doing good dural repair will give you a good results. So I have done the complete excision. Patient came with the weakness, right? So this the more zoom view. So you can see the brainstem, the cerebral peduncle. So other side is compressing this way. You can see this artery coming. So some of the vessel is there. So just take this out without damaging this one. So you will get the good results. It's a complete recovery. After 5-6 months, patient is just walking into the clinic without any deficits. So it is alarming. So it is interesting. So this is really complicated case. So I started the small one. So when you see this one is complicated. This patient's the presentation was the lady, she had a proptosis. So the globe is pulling out, and there's a fullness of temporal area and little bit of headache. Because of that reason, the MRI had been done. So you can see the problem coming here. So this is a normal orbit. This orbit is pushing out, right? This is a normal bone on a normal side. You can see the bone is very thick. That is hyperostotic bone, and soft tissues all swell up because of a tumor. And when you go to this place, you can see the little bit of nerve that is obstructed here. You can see some tumor is going into the orbit, and some of a tumor is in the middle fossa. And so this is a sphenoid sinus coming here, and other side the sphenoid sinus is full of tumor, right? And compared to other case, the vessels are little away from a tumor. Now patient coming to me and saying, doctor, I have this problem, eyes popping out, pain here, so give me some solution. So in Kurunegala, what I can give? So there are different offers. So one is just take this piece out, repair this part, give for radiotherapy. The problem is if you leave this piece, definitely she will come with the recurrences. And when this is growing up, the COVID will come out, right? So you need to go for a complete excision. So how we are going to achieve it? So you have to take this piece out, take this piece out, take the piece inside the sphenoid sinus and repair the bone, repair the dura without damaging any of these important structures. So that is it. So I thought best to go for a complete excision. So I went in a base, part of the orbit, lateral wall of orbit removed, segmented arch, I have cut and take all these tumor out and went into the sphenoid sinus, just inferior to the optic nerve, and I couldn't negotiate and take the upper part of a tumor lying on the sphenoid sinus. I went above to the optic nerve, perforate the whole roof of the sphenoid side, went in, took the whole tumor out. And I prepare the dura and reconstruct the bone with the titanium mesh. So this is a coronal view. So you can see the hyperostotic bone, huge one, sphenoid being full of a tumor. This is a normal orbit with some muscles. See the what happened to this orbit. But you can see the sinus, the meningioma tissues coming here. So just to elaborate some more, so you can see the orbit is coming. So I pictured it to have a nice picture. So this is what I did post of CT. So you can see the stigmata of cutting a zygomatica, spacing it. So all these things I have removed, and part of this bone I have reconstructed with the titanium plate, and these are the normal bone. Right, this is a post of MRI. So you can see the normal side, optic nerve, globe. Interestingly, now globe is going in, settle everything. So you can see the optic nerve here. Now you can see the wrinkling of optic nerve. Right, all tumor is out. All tumor is out. Sinus is free of tumor. And when you look at this one, so this side free of tumor. No, this is the CSF collection, and you can see the sphenoid sinus is free of tumor, and you can see the perforation of a skull base. I have entered into the sphenoid sinus. Yes, you have images, good images. What happened to the patient dying in that coffin? Yeah, she is coming to see me in a clinic. She is completely alright. Eyes normal vision. So you can see some scars coming here. No weakness. This is after 6 months. Yeah, good. So meningioma, a few cases. So these are the routine cases, but these tumors sometimes can come as an emergency. Right? The story behind this is the lady followed up in a psychiatric clinic for some time, admitted to our unit with a low GCS. On admission, GCS was 12. Had some seizures. So this is the initial CT, non-contrast. So we treated initially with a high dose of dexamethasone, oxygen, elevation of head, that sort of things. And then GCS improved around 13 to 14 line. This is a post-op, the contrast CT after 24 hours following day. Right, you can see huge tumor coming from the skull base, pressing everything in. So you can see this side, the ventricle, can't just see it, just can't see it. Other side, little bit of ventricle. So now the problem is patient is in the ward. So what you are going to offer for these patients? Relations are coming and asking, doctor, this patient is here, he is almost unconscious. I mean, Jesus and all, what you are going to offer? So if you are going to do a surgery on this one, definitely someone will ask for an MRI. So because you need to know where this optic nerve at the base, the tumor is sitting on the optic nerve. So where is this carotid arteries, middle meningeal arteries, middle cerebral artery, anterior cerebral artery, all sort of structures. So you can't get any information about all those structures with the CT. But patient is waiting. So next option is to transfer this patient some other place to get MRI done. So can I do it? So probably no now. She is in a critical state, going to die. If you transfer this one to some other place, it will take another 2-3 days. While that time she can die. So what you are going to do? Are you going to get a challenge? Go ahead with the operations or send her away. So this is my problem at that place. So I thought, no, I have to do this one because there's no other way of saving this patient life. So I decided to do it. I did a frontal craniotomy, went up to this place, took whole tumor out. That third day of admission, right? Then I managed to extubate the patient, send the patient to the ICU. So this is 40 hours, for the second post-op day. You can see whole tumor is out. This following day morning, patient is lying in the bed comfortably. All limbs are moving. Some line you can see she is much more comfortable, right? Then after third week, she is coming to the clinic, walking up to the clinic. So that's why I am telling meningiomas, treat aggressively, well planned, do it. You can save patient life. So all these patients, when you come this type of big problem, don't be panic. So reassure them, send to a neurosurgical center. They will do surgery. You will get the good results. This is a complete cure. Right? So this is some other thing. So all are very familiar with these pictures. Right? So this one, if you go into little things, so we think very simply, right? So this cerebral tonsil, so spinal cord, you can see the vertebral artery coming here, this, and it's going inside. So this is a lateral mass of atlas. This is a joint, right? This is the C2, right? One other thing, you can see how the vertebral going on. So spinal cord here. So why I am interested on this picture? So we are getting problem on this area. So just imagine if you have a tumor here, a meningioma, whatever, in this place. What you are going to do? Patient will come to you with all sort of neurology. If you have cord compression here, so they can have all this lower limb, upper limb weakness, spasticity, the swallowing problem, headache, neck pain, all sort of issues. So now the problem is if the patient coming with a tumor at this place, so surgeon has to take it out. So what are the approaches? Can you go this way to approach this nerve? That is not possible. So much of structures. Then going back, coming this way up to here, cut the lamina and going. The problem is when you go back, so this spinal cord will say high to you. So you can't retract the spinal cord this way or that way to go in. So if you retract, you will confuse the cord. They will end up with all disasters. Right? So that approach also not possible. So other thing is to go from this place in. Saving this one, take this tumor out. See, going this way. Not an easy case. So you have all these vertebrae, you have all these nerve roots, the element from lower cranial nerves. So you have to save all these things, go in and take the tumor out. So if I get a tumor, so same thing. So meningioma, anterior. Sorry for this one. Actually, so this is foramen magnum meningioma. So anterior place one. So this is a big tumor coming here. So see what happened to the cord, right? In a coronal, you can see the vertebral artery touching here. So this black layer is the cord, and this one is the tumor. So this patient actually around 40-year lady. One day one of our neurologists called me, Thilak, look, I have a patient, quadriplegic, just lying on a trolley, can't walk, can't eat, on a GTU. So I don't know whether you can do something for this one, but anyway, I am sending the patient. So what to do? So I thought to go in laterally and take all tumor out. So I did the surgery, take everything out. You can see the scars of a tumor, the tissues, and it's a post-op MRI. It's completely gone, and the spinal cord is completely normal now. Patient is sitting here, came to my clinic, see my clinic, all this wall and all. She's perfectly all right after 6 months. It's a good result. And some more complicated case. So the Kurunegala is very heavy. All these cases are coming here. Kurunegala. So same story, lady. This case is much more complicated than this. It's a little bit higher up compared to this. And you can see the spinal cord pressing this way. And this bad eye is looking here. Right? These are two vertebral arteries that is within the tumor. You can see this one. So you need to take this whole tumor out, saving both vertebrae, saving all these nerve roots, spinal cord, cerebellum, and do a good dural repair, not to have any sort of CSFE. So one of a challenge for us. So this is a sagittal view. So what I have done. So this is a post-op MRI. You can see a little bit of damage happened to the cord. So white stuff. This is the resolving cord contusion. And coronal section, you can see the vertebral here, all tumor is out. So I managed to take all the tumor out, saving all these arteries. I don't have the post-op picture of a patient. She recovered completely. So what we need, we are doing all this in Kurunegala. So we don't have big bed, no expertise, no MRI, nothing. So we have this one, but so we work like a team. So anesthetist, ENT surgeon, we work like a team. Like friends. That is one thing. And we never say no for any challenges. Right? And we are confident. Our team is confident. And based on this, we have planning. So we are going this way. If you fail, we have some other plan. And we have different options. So our surgeries are more successful. The spine back. So a little bit of a brain surgery is meningioma. So I will go fast. So little bit to remember of the spine. So this is a strong, rigid, but it is flexible. That is a problem. So when it's flexible, you get all sort of degenerative problem. And inside you have a neural element. So it is so complicated health problem. So if you're going to address, make it rigid at the same time flexible. And so you need to protect all these neural elements. So because of this complex nature of the spine, generally outcome is poor. Really challenging to the surgeon. So a little bit of the anatomy. I think if you can remember a little bit these things, it might help you. This is a CT of the cervical spine. So how they do it? This is a coronal one. They start cutting from this place, getting the images and going to other side. So this is a line, so this is the first cut. So it's going so on, and this is the midline. So other side. So I want you to remember very few things on the CT. So one thing on this spine, when you have this kind of neck injuries, the spine is stable or not. So without going big thing, just remember very few things. You can do it, it might help. So go to the midline one right here. So you can see this line coming here. It's an anterior spinal line. This line posteriorly, it's a posterior spinal line. So you can see the lamina is here, a line going there into lamina and the interspinal line. Right? So if all these lines are parallel, there's no any displacement of vertebral bodies, right? Then you need to know how stable this spine. So to do that, you need to check the facet joint. So these are the facet joint. All these facets nicely placed. So this side facet, all right, and check the other side facets. Right here, it's all line up parallel. So that means all facets are normal. And these bony pieces, small one, you call it pass, C2 pass interarticular. This is little different. So that connect the body into the lateral mass. So that's one bony structure that maintain the craniocervical junction stability. Right? If you can remember this tiny thing, especially the people working in A&E might help. So another story. This is about 65-year-old male came to me, screaming of pain, couldn't walk, couldn't eat, just sitting on a wheelchair. He can't just extend his neck, just keeping this way. And saying, doctor, see, I am agonizing pain, I can't talk, I can't eat. So because he can't eat, even other people can't feed him, because he can't just extend the neck. Agonizing pain, crying, and asking me, doctor, do something for me. So whatever the convince, he says, no doctor, I need some sort of solution. So only solution, so see there's a curving on this one, some damage happened to this place, right? So only option is to cut this place, raise this some, straighten it up, put some implant, plate it or make it stronger. But the next issue is, so if you are going to do a surgery, you need to know what happened to the neural element, the spinal cord. So for that, you need to have MRI. Now my question is, so how we are going to do the MRI? This patient is crying in pain. You can't keep him in the MRI machine for at least 45 minutes. So you have to sedate him. If you are going to sedate, if anesthetic is available here, I don't think they will agree, because if something goes wrong, how we are going to maintain the upper eye? So that is a question for me. But patient is crying. I couldn't get the MRI done, and at least I couldn't try to do this surgery. So anyway, patient said, doctor, anyhow I need some. So I said, I can do this one, but you can die while doing the surgery. He says, no, that's not a problem. I need surgery. So I am happy. So I thought, anyhow I'll do surgery and go and talk to my the anesthetist. Oh look, so how you are going to do this one? So he will die while doing the intubation. So big problem. But anyway, our anesthetists are always good. We can negotiate with them. So he says, so if you are taking all this, we do it whatever the complication we are going to do. So I did this one with a simple X-ray. I cut this part anti-relevant, take this whole thing out, keep the dura intact, straighten this up, put a titanium cage and take it. So this is a post-op MRI. You can see the cage coming here, plate coming here, complete extended. Now look, patient coming to see me in the ward. He's walking up. Earlier he was in a wheelchair. So you can do all. Some other case. So these hangman fractures, very common. We all know this is what hangman fracture. So this hyperextension injury, because of extension, you get the fracture of fast interarticular, what I showed in that CT. So this is a lady came to me Kurunegala after road traffic and fall from bike. Neck pain, some weakness on upper limb, lower limb was alright. So when you check this one, you can see this pars internal artery is broken off. This whole segment, upper part, is moving away from the neck. So olden days, people manage this one with the different causes, braces, and external appliances. But outcome is generally poor. So surgical management has to be, you need to put 2 screws here from atlas, lateral mass going this way, and 2 screws has to pass from the pass interarticulates in the body, and 2 screws the lateral muscles. So then you need to correct it. So patient will survive if you can do it. So we are doing all these craniocervical junction surgeries. So this is 1 year after surgery. So I managed to put 2 screws. These long screws go into the lateral muscles and correct the fracture. 2 screws to the lateral muscles. Complete recovery. 1 year after surgery. No weakness at all. I don't have a picture of that patient. So some of the challenging cases I did in Kurunegala with good results. So when you go in the searching net and all, one day I get this picture. So it is not my idea. So it is good to know. Change your thoughts and you change your world. So we don't have much facilities at Kurunegala, but we change our thoughts, right? So we have changed then the patient world. Another interesting story. Actual story I will tell. This is not a story. One of my friend, a surgeon, calling me. Frankly, he called me, Tora, I have patients. He is having nasal bleeding. Rhinorrhea came to me and whole sort of investigation with the patients, and says there's a big aneurysm, and say not to operate this one, unable to operate this one. So you have to go home, live whatever the time. Now patient and coming and crying to him saying he's having nasal bleeding. So my friend is calling me and saying, Tora, can you do something? So they say there's some aneurysm in the internal carotid artery, say not to operate, and it's very difficult. So I feel I have to look into this one. So I said, my friend, so send me the patient. So no, he's so poor. So I said, so send the images to me. So following day morning, wife came with the bag full of images, so much of images. So this is one of the images I took from that. So you can see the huge mass coming here. This is a huge aneurysm, internal carotid aneurysm. So you can see the layers of blood. And this is the ethmoid sinus. The aneurysm is going into the sinus, eroding sinus, and leaking from this place. So this is the part going into the internal carotid, the cavernous sinus, right? And amazingly, the fellow is saying some other aneurysm on other side. You have 2 aneurysms. This is the problematic one. And at the same time, globe is coming out. He was blind, and the chemotic red dye, some oozing coming from that. So lady is crying me. So that patient is going to die. So what you are going to do? Can you do this one? So that what I asked. So he said, so there's no other solution. I said, so this is a very complicated story. If you will, I can try. So this is the MR image of that patient. Somebody has done this one. So you can see the one aneurysm, huge one coming on, and other side, similar aneurysm. So I thought to operate on this one. What I thought was, take whole bone flap from this place, deep down to here, right? Try to expose the internal carotid and try to catch this place. And at the same time, before surgery, I plan to get the carotid distal, the control with the technique section. So I took the internal carotid artery, loop it, and did a big craniotomy, open this way, and went in. So amazingly, I can't reach any place on this place. It's a huge aneurysm. It's just pulsating like this. Scary. So there's no solution. So I just dissect inside the brain, and fortunately, I could try the internal part of the intercerebral part of a carotid artery. That is one goal. So I achieved that. And then there's no solution. I put a small clip into the internal carotid artery, intercerebral one, and tighten up the internal carotid artery at the neck. Then I divided it, suck out everything. So there's no that some bleeding coming from this cavernous sinus. So I packed it. So there's no other solution. So then I get the hemolysis like it, the internal carotid, right? So then I saw patient will die. Fortunately, after 12 hours, I took the sedation out. Patient was all right, no weakness, is recovering. Managed to extubate after 12 to 24 hours. Now people think your problem is over. That's not the problem, it's over now. So I am a now big problem. See, now I address this one. So family was accepted the death earlier. Now I done this one. Now he is living. Now they won't accept death again. But problem is again there's some other aneurysm. So now I am scaring what to do for this one. So this side the internal carotid is not there. Now he is living with one internal carotid. So if I go to this side, what will happen? So if you damage this one, definitely is going to die. Now family is well, alright, but I am burning with pain and all. So what to offer for this one now? So I thought I didn't have any plan. But after 3 months time, I did the DSA just to see what's happened to this lesion. So DSA came, there's a tiny aneurysm coming from this over to the clip and all. So that is surgical thing, but nothing mentioned about the other side. So I said, so this is very unlikely. Probably the report, so somebody has not concentrated on this side. So I leave some time, give about 2 months, and did the CDHU at the Kurunegala. So you can see the vertebral arteries coming here, posterior cerebral, posterior communicating, other side internal carotid. So middle cerebral arteries, anterior cerebral, so other side middle cerebral. So you can see the tip coming here and touching this the tip on internal carotid. So amazingly, other side I can't see the aneurysm. So I don't have solution. So aneurysm says it's a permanent thing. You can't accept any. There's no any the cure. So I don't know. So this is a problem. So this patient coming is all right. Blood completely recovers, no weakness. He says now I want to go for work. I said, yo, you can go to work. But my problem is what happened to this one. I don't know. I didn't have any experience on that kind of thing forever. So if anyone have that time, so the answer for it, I am very welcome. So now patient is all right. This the security man, wife is wife working in a garment factory, having 3 kids. They're crying and went out. So then something about the vascular gliomas. So they are blah 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 blah, lot of things. So I don't think you need to remember all these things. So meningiomas is curable. You need to aggressive treat it. But gliomas, you need to get a good control of a disease. That's the message. So just forget all these. If you can get a good control of a disease with a surgical excision, chemoradiation, you can extend the life. That is the goal. So I don't want you to remember all these things. Leave this one for us. Another case. This patient around 40-45 investigated in some place, invested headache. Because of headache they have done an MRI. Neurologist referred to me. You can see the huge tumor coming here, this glioma, big part of a glioma inside the brain, the ventricle. Other side ventricle is very small, right? When you see this one, you can see the glioma coming here. You can see the corpus callosum. So again challenge. What are the options? If you want to give good cure, you have to do the complete excision. So complete excision, how possible? Or otherwise, do a biopsy or debulking or for chemoradiation. So if you are going to do complete excision, how are you going to approach this one? So those are the problem for me. So I thought to do the complete excision going into the ventricle. So when you think, so nature is always helping us. So if you are going this way, you have to go through all these big the parenchyma, craniotomy, cortical. So that is difficult. So what I thought, so do a craniotomy here, take this bone part out. So you get the interhemispheric fissure. So frontal lobe, frontal fold, retract this way, go into the corpus callosum, cut the corpus callosum, and enter into the ventricle and take all these tube out. So that is a standard surgical approach. All surgeons know that the callosotomy and entering the ventricle, standard one. So I thought to do it. I went in, take all tube out. This is a post-op MRI after 3 months. So all tube is out. This is a ventricle. All tube is out. I didn't put any chance EVD. I put a EVD, but after that there's no any chance, no hydrocephalus. So what happened to the patients? Weakness on a wheelchair, behavioral issues, some other issues. The patient is walking up to the clinic. This is my, you can see my clinic. He is completely alright. No weakness, nothing. This is 15. So successful cases. So always trying his best. Never forget. Never give them up. Try your best. One day you will get the good results. This is some other case. So all these cases coming to Kurunegala. This patient referred to me by one of my friend, ENT surgeon. Called me, Thora. This the common word, Thora. Patient came with some nasal discharge. I put a scope. I can see big massive lesion in the pharynx coming from all the way up. I've done MRI. This is the MRI. I don't know what to do. Can you do something? So see a tumor coming from this place, going all the way down to hard palate. You can see the sphenoid sinus here. Tumor is going this way, right? Here the cut. So part of it is involved in the orbital roof bridge, and some tumor is inside the brain. So what are the options? So everyone will think just do a biopsy, do radiotherapy, or going for a complete excision. So you can do the complete excision. Next, what are the problems? So if you do the complete excision with orbital roof and all, you have to reconstruct it. And at the same time, you have to repair the dura. At the same time, you have to repair the pharynx. And you should not leave any CSF leak from brain to the pharynx. So are you going to get your challenge? So I thought I can do it. So I put a patient GA, bicoronal incision, raise the flap up to this nasal bridge, opening all eyes. Right, this is for just after finishing the surgery with the help of ENT surgeon. So you can see the part of bone, frontal bone out. So orbit, lateral wall, orbital ridges out. You can see the nasal bridge here. So I went in, took all tumor out, repair the pharynx, and repair the dura, and put some bone graft. That is what I have available in that place. And I reconstruct the frontal bone, orbital ridge, nares, and all. This is a simple flat titanium things coming. So I did all this the tinkering work in my theater. Right, nicely placed one. So you can see the plate is sitting nicely in this place, orbital ridge, nasal bridge, perfectly fine. So all these are tinkering work, not the neurosurgery. So the results: patient dying, blindness, CSF leak, weakness. This is a patient after about 4 weeks time. You can see the big scar going here. He can see nicely. Orbital ridges, nose, everything is normal. Complete recovery, no complication at all. Now he is following it up and clinic. Radiotherapy was given from Kandy. So a little bit of story. So the secret of all these surgeries, so especially my juniors. So what are secrets? These are the secret. So we go another case. So this is common for all the medicine medical field. So we talk about the cases. I never talk about the cases. This is patient is not the case. Can be mother, can be father, brother, sister, or daughter, whatever. Treat them like your own loved one. Treat them with dignity, love, and kindness. So that is the secret behind all the success. So my message is, so don't think too much, right? Select the patients, treat them well. Neurosurgery patients, they are not going like this way. It's a wrong message in the society. So we need to change this message. So if you do good job, they will go home. That is my final message. Thank you very much for listening.
Thank you, Dr. Thoradeniya, for your excellent talk. And it's amazing that how you have done your job and with minimal facilities. Very much question that you asked. I think Dr. Nia said you were planning to ask questions from the beginning. Because the moment I go into the morning, he said, I'm going to come and I'm going to ask.
I just want to excite Chaturanga, that's all. Anyway, thank you very much. I have the questions. Amazing work. And you are the second slide, that is patient and the coffin.
Yes.
You can't blame anybody. You know, that was the practice.
Yeah.
That was how it happened. And that's how people were able to do. And I remember, respectfully remember my neurosurgeons, my time. And with the limited amount of, they had only Hudson's brace, and they didn't have any electrical saw and whatnot, etc. So with those things they did, and the outcome was poor. Thanks to you all now, a lot of confidence now, and among the neurosurgeons, and you all do great work. And now the outcome is excellent. And good to see, Thora, that your work in Kurunegala is amazing. And congratulations, you keep going and improve on. And I have to tell the juniors, when we were in Maharagama, great surgeon Gabriel wrote a poem on the door of the consultant launch. It's a long poem. The last few words told, now we do everything with nothing. That's what he did. And that's how it is. It's not the instruments and equipments and sutures and material. It is the will. Thank you very much. Yes, congratulations to you, and good job done. Keep going.
Thank you very much, sir. So
what about your, emergency? You were talking about the elective surgery, so the workload and, depending on the place you have worked, what is your views on emergencies, neurosurgical?
Neurosurgical emergencies. So we have a basic principle. So that is, so you can't prevent the secondary insult. So if something happened to the brain, so that is forever. So if a patient coming to you in emergency, say the trauma, so initial damage is very severe. If it is not compatible with life, big damage. So whatever the surgery is not going to make any sense. They die. So if the patient is coming with some sort of brain with functioning element, if the initial insult is not that great, severe enough, so you can do all these maneuver to prevent the secondary insult. So that is edema, ischemia and all. So those patients will recover. So the outcome on a trauma situation, emergencies basically depend on the severity of the initial insult, initial brain damage.
Can I ask a question, please? It was a great talk. Congratulations on your
Thank you.
good results. Um, that third case where that patient was followed in a psychiatric clinic for
Yeah.
some time, and then
Yeah.
how long was she? Are you aware how long she was there? And did the psychiatric manifestation completely disappear after your surgery?
So this patient, I think she had been followed up in the psychiatrist more than 1 year. And so I did this one about now 4 5 weeks ago. So just after the surgery, I didn't stop any of her psychiatric treatment. That is not suitable because she need to have some time. And many occasion, what I experience is after this big meningiomas and all, the recovery from this psychiatric problem is not that good enough. So you need to continue this antipsychotic treatment for some time because that damage already happened. They are quite used to that treatment. So basically, they want the psychiatric element is not just disappear after surgery. You can save their life.
Can I disturb you for last time? Thank you very much for the presentation. And it's amazing numbers, thousand. And out of the thousand, it's like to know how much ended up in the ICU. And it's amazing ICU. You know, we know that one very difficult. But how do you manage all these?
Um,
Cases in a well-bedded ICU, which is not actually for you. It's a common ICU that you are managing with the other patients.
yes. Oh, so that is the interesting question. So basically, neurosurgery, one principle is so always you try not to manipulate the brain. So not to damage the brain while you are doing the surgery. So no, do not make any damages, do not make any edema, do not make any insult to the vessels and all. So you can save your neural element. If you can save your neural element after doing surgeries, you are decompressing the brain. You are giving it a lot of space. So if you can do that safely, just after the big surgeries, safely you can extubate the patient. So in a Kurunegala, very occasionally we ventilate the patient after surgery. So immediately we extubate them, and many occasions we never use the mannitol. We just use the 3%. So probably the we are managing with the ICU because we never ventilate these patients unless we have real doubt about the cerebral edema. So our aim is always we go for a little big craniotomy. We always try to take the tumors without manipulation of the brain. So we are minimizing the brain damage. So that may be the one reason. That's how we are tackling with the surgical care. And we don't keep them in the ICU more than 1 or 2 days.
I think Dr. Udani